So I'm going to start our webinar of the Brazilian Journal. Good evening, everyone. First off, I'd like to thank all of you for your presence, for being here with us. And this is the second Brazilian Journal webinar of this year in the 2023 season for webinars. We had a great webinar last year regarding science fraud, a webinar that was on a subject that was quite intriguing, something that must be discussed, and we will continue to discuss this during the year. And this month, we will have a more technical webinar, specifically on an area that is quite innovative within anesthesiology and pain control. So this is a webinar that was selected by hand, so by the publication readers and members of the Brazilian Society of Anesthesiology, due to being a matter that a large number of recent publications, it's a pretty interesting subject matter for the present and the future or specialty. I'd like to inform you as well that we have real-time translation towards English so that we can have a wider reach towards other countries on this activity. And this activity, it is stored, it is saved, and it is shared in our YouTube networks with you. So all the webinars that were done from the start of these activities during the pandemic as well, up till now, they are all saved, recorded, and they're shared on our network. So I'd like to invite everyone that was not part of this whole activity live. You could later access our networks, and you could maybe like or share our shared content, and you could share the content with your colleagues and your peers, because these are pretty interesting activities. We have gotten some really positive feedback from our peers. And within these activities that we've shared on YouTube, this year we started to share a few videos, short videos from authors that are responsible for our main publications. Will comment on our articles. This is a new activity that has been done. I think it's going to be pretty interesting so that we can have a wider interaction with our colleagues that read and publish on these publications. And a few many classes we will have the recording of a specific class on transparency and fraud in scientific research, a similar subject to last month's webinar, and this class will be recorded with Professor Federico Bellota from Sapienza in Rome University. So this will be recorded and shared on YouTube with our colleagues. So we'll have further interaction with our readers and our colleagues that access and publish on our publications. So starting our webinar with the meeting today, we'll have the presence of Professor Jairo Alberto Dussan-Sarria. He's a graduate of medicine with the University of Los Angeles in Colombia. He's specialist in treating pain and palliative medicine through the Rio Grande do Sul University and a clinic in Porto Alegre. He has a PhD in medical science to the Federal University of Rio Grande do Sul and research fellow of Harvard University. From SBA, he is currently a professor of anesthesiology in Cevale and anesthesiologist in the Hamburguesa Anesthesiology New Hamburg Clinic. So he is associate and a fellow on neuromodulation and advanced rehab Minerva in New Hamburg in Rio Grande do Sul, dedicated institute towards clinical and practical research in neuromodulation, non-invasive neuromodulation in the brain. Also, Professor Jairo, he's a great colleague, he's a great friend. We had the chance to work together at the hospital. We know about his skill and his expertise during practice contributed quite relevantly to the magazine through publication of his line of articles relating to the research line within neuromodulation, as well as the peer reviewer in the magazine has performed some great peer reviews that contribute to better quality of the papers that are published in the magazine. So it's an example within Brazilian anesthesiologies that have contributed quite strongly to the evolution of our publications. So I'm quite honored to pass the microphone to Professor Jairo. He will be speaking about transcranial stimulation through continuous current during pain treatment. So please, Dr. Jairo, go ahead. Andre, thank you so much for calling me over. Thank you so much for this generous introduction and the presentation. I really need to thank Dr. Andre. He was my preceptor during my residence in Porto Alegre, and to congratulate you for the exemplar work that has been done with the Brazilian Journal of Anesthesiology. Really, it's a scientific unit. They need quality that will get needs to be published. So this is an area that we still need to work on within medical sciences. So congratulations for all the work you've done. Oh, I'm not gonna lay myself below any further for our schedule. I want to share what we call TDCS in English, transcranial direct current stimulation for pain management. Well, I'm from Colombia, so I'm gonna use TDC. I'm gonna use TDSS for pain management. Can leave the translation the same. So, seeing you have the conflicts of interest, there are more intrinsic, really, as an anesthesiologist in the anesthesiology field, as a professor of Fifth Valley University and as the associate founder of Minerva, we try to bring inflation much closer towards brain stimulation, non-invasive brain stimulation. So today, electrical transcranial stimulation, but in the institute, we work on the clinical side of things much closer towards magnetic transcranial stimulation than other brain neuromodulation non-invasive technique. And when it comes to transcranial stimulation, we have several new types of devices, new types of electrical currents that are being instigated closer towards the research. Show you a bit of the context of non-invasive brain stimulation. I brought a review article. This is an image that I borrowed from this edition. It's from 2021. Tries to give you an overview of non-invasive brain stimulation, some principles on the clinical applications, and what I'm interested the most in to make more interesting for all of you is this image that gives you an idea of non-invasive neuromodulation. We're talking about neuromodulation is that we want to induce some sort of change within cortical circuit. We induce this, and will be much more familiar in a non-invasive manner for us anesthesiologists with deep electrodes and Parkinson's disease, non-invasive. We do this frequently when implanting peridural catheters or eventually some long permanence catheters for oncological matters. But the idea of brain stimulation that is non-invasive is not to employ invasive techniques to induce this change in neural circuits, especially in the brain. I really like this image because it gives us a practical vision of where the clinical side of things are and when the research side of things is when it comes to non-invasive neural stimulation. It's older, but it's still a form of non-invasive. It's electrocampus therapy. It's older, but it is quite evidenced or precise because it can be a divider, especially when it comes to serious depression, postpartum, catatonic syndromes. It's really a very favorable technique that when it is uh, pertinent. I've seen a very dramatic scenario regarding transcranial ultrasound. It's quite popular in our day-to-day life, but with a clinical outlook and objective, with good scientific basis, we can this can have very pertinent therapeutical conduct. Another form of non-invasive neural stimulation is sketamine, which was recently launched into the market with a Spravato name, which is through a new form of administering, which is all intranasal, which has a good amount of research showing that it helps with depression, slow response, but the treatment can help to diminish the risk of suicide in these patients with depression. And much closer to our subject is transcranial magnetic stimulation. With magnetism, magnetic stimulation, transcranial, and then there's electrical stimulation, which we also discussed today. There's also ultrasound stimulation, which probably Brazil, it's the newest side of things. Magnetic transcranial stimulation has a history of research that is much wider It has approval by the SBA and the European Society SOA for treating serious depression that is resistant to treatment. Has approved. It's approved for OCD disorders for facilitate this feeling of the use of chemical substance, especially alcohol, and a number of all also neuropsychiatric indications. And for electrical stimulation, well, we also there are also several types because electrical current can be delivered in several manners. It can be continuous current, it can be alternating current. We can also use white noise, or maybe you can place the electrodes within the current. We can stimulate nerves as well. And I have a small picture a couple of years ago as a demonstration of a child. They have some straps on their head. We use these straps to administer electrical stimulation therapy, transcranial or TDCS, as we call it. And I really like the picture because it helps you to show the scenario where the clinical practice would have an interesting role. It's a non-invasive technique that involves simply placing electrodes on the patient's head. It is not uncomfortable. Eventually, it could make it so that a person could be portable. They could take it home and they could perform the transcranial stimulation themselves. They would not need anesthesia as we perform this in therapy. So this is the outlook for non-invasive stimulation. But how does TDCS work with continuous current, as we say, TDCS? On your left, we have an image that presents how this works. We have a stimulator, a generator. This generates a continuous current
Vai até um
for a couple
seletor.
of wires. It goes up to the electrodes. They're placed on the patient's head. So with a continuous current, we provide a current flow. The electrons will go from one electrode to the other. Generally, the electrons will leave is the diode and the cathode. The anode goes to the cathode. So it has a direct current flow, as the image shows. We, the researcher or the clinician, determines where these electrodes will be placed. We tend to place it on the patient's head, but depending on the intent of the therapeutical session, it's important to define where the electrodes will be placed. In this example, in this drawing, the electrodes are placed in the frontal side, the upper orbital region of the head. But is a lot more behind this technique. This image gives you a proposal. For the continuous TDCS administration, we can place this combination of electrodes in several places. This gives you a certain versatility to research and a versatility that's very interesting practice, but at the same time, it can end up becoming a limitation at the time of generating evidence and aggregating this evidence to give you a response for clinical utility, because there's a lot of combinations for sizes and electrode positioning. And depending on the patient we're dealing with, you need to choose one or the other. So the TDCS with a continuous current, well, it's a continuous current. And down here to the left, we have another image that represents as we understand this happens. Over time, the device, this stimulator or generator, generates a gradient, a voltage through which it delivers a current. You can see that on this chart, it says ramp up and then ramp down. So what happens is that through clinical research, we observe that with a determined amplitude when it comes to deliver this current, it can be can be useful for the patient. So it can be uncomfortable. So to diminish this discomfort, we can have a gradual increase in the current until you reach the desired current. And once the therapy is done, it will be a gradual diminishment in the intensity of the current. This is specifically due to the discomfort that this can happen for the patient. and better tolerance for the therapy. So to your right, you see several elements that is interesting to remember a bit about the clinical research on the transcranial and continuous current therapy. It employs a continuous current. I point this out because there are more recent pieces of research would have alternate stimulation with a pulsing current electrical pulses, not a continuous current with white noise, which involves oscillating ranges. There's also randomized current frequencies. It's described as a white noise, which has a potential to have a therapeutic effect. Generally, we use between 1 to 2 milliamperes and above 2 milliamperes. It's not very tolerable. It can have adverse clinical effects, what we want. So it depends on when we place the electrodes. To get the clinical effect that is desired, it will depend on the position of the electrodes. There is so that it's just so that we don't lose energy in transmission to the scalp and the electrode, as well as the positioning where we determined where the electrodes will be placed. And depending on where the current goes, the current flow, we speak about anode stimulation and cathode stimulation. You will find both forms, and it refers to, well, we'll replace the anode and the cathode because this discrimination, well, when we research this on animal testing, you see that the cortical tone that is below the anode tends to develop an increased excitability in the neurons, neuronal excitability. So this delivery of continuous current, depending on its range, it does not generate a neuronal activation. So if you use a TDCS on the motor cortex, you will not generate a motor response. It will change the resting potential of this neuron sector. It could affect the spontaneous neuronal activation. Now, when it comes to the cortical territory that is below the cathode, will have the opposite effect. It will diminish cortical excitability and can increase the neuronal hyperpolarization. So it will be more difficult to activate a neuronal activation in this specific sector below the cathode. These affirmations regarding the electrical aspect, let's call it this way, the transcranial, the TDCS, these are valid as they are described between 1 to 2 milliamperes. When we increase the intensity of the amplitude, if the patient will tolerate this, we can have a neuronal activation. We'll have other effects. All right, so I perform a session, I have a therapy, I am administering continuous current on a period of time that this can change. I understand this in the territory, but once I have finished my session stimulating, will this effect last? It's interesting for us as clinicians, as anesthesiologists, because I cannot leave delivery. It can't happen the whole day. The therapy that is being applied, it needs to have a lasting effect. And the answer is yes, the duration of the effect will depend on the duration of the session. A single session can have effects to last between 1 to 5 hours of time, but according as we continue to repeat sessions, generally clinical protocols suggest to perform 5 sessions per week during 2 weeks, 1 session per day during 2 weeks. We observe that effects last over time. How much time they last, well, that is still something that needs to be answered. Generally speaking, we understand that activation of the increased enrichment of cortical activity is more related towards non-therapeutic alterations. We know this through experimental research on animals that have received antagonists and on NMDA receptors. Those that have antagonists and NMDA receptors do not present these secondary effects, and the chronic effect that sometimes or will repeat themselves over a few weeks. It is believed that this is related to long-term potentiation phenomena and long-term depression phenomena, which are related to GABA channels. And this is interesting because in the clinical practice, a patient that has a neurological alteration that is frequently huge amount of medications. Frequently, they have mediation, winter, and MDA receptors and the GABA channels. So we do know that it has clinical effects. They diminish the long-term effect of TDCS. As you know, this coding mediation, this increases the conduction on the GABA can channels. So among these small tips, a few tips that how TDCS works, we all already have an idea of the complexity of bringing this technique towards clinical practice. So very long sessions, more than 30 minutes long. Generally, a TDCS session will happen over 20 to 30 minutes. And for those with uh, a higher amount of milliamperes will have adverse effects according to protocols that could cause opposite effects what we want. So that's great. But does a small current on your scalp, will that be able to reach your cortex to be able to change, have relevant changes in human behavior? Well, the answer is yes. We have clinical evidence that there are behavioral alterations through scales that we apply during clinical practice as well as clinical research. We can observe this on the alterations on anxiety and depression scales, pain as well, as we're going to see today. But beyond that, we have assimilation and the visual representation, at least visual representation of how the distribution of the electrical continuous current occurs between the scalp and the skin, the cranium, actually up to the cortex. This is these images. The simulation tends to be called continuous element simulations. Under red, we can see how the simulation suggests that the current can reach up till these surface regions of the human cortex, brain cortex. So we have had tests in animals where they place the small electrodes on the small critters scalp, and we can see where the current will reach, and we can have psychometric responses that confirm that these little shocks, this current on the patient's head, yes, it can induce relevant change and behavioral change as well. So how is it physically occurring? So for those of you that never see this, well, we have different brands. I have no conflict of interest with any brands, but it's just so to show you and you have an idea the complexity of these devices. There are apparently simple ones, like simple analog devices where you turn a dial to apply the current, and then there are more complex ones, like the ones that we tend to use during research. They have very little availability and when it comes to buying these, but through these we can determine the characteristics of the ramp up, what is the intensity of the current that want to provide. We can blind these, so we can, for those of that are having a TDCS within a research context, so we can have the blinding in a blind research. So there are also more elaborate devices where you can actually operate the characteristics of the current. And then there are these touch screen devices that can make things easier for the user. And then there are pre-molded caps to facilitate the attachment of the electrodes. And there's few researchers. There's one that was or my guidance, my guide during my PhD. They developed a transcranial device and a cap to get this therapy done at home. So we call this TDCS at home. It's pretty self-explanatory. So you can see that these are devices that can go from pretty simplified devices. The intent is to make it easy to use, but we still depend on the correct placement, the correct positioning of the electrodes on your head. So what are these things that we place in the head? Well, these are the electrodes, those that we are familiar with when it comes to monitoring on cardioscopy and a continuous electrocardiogram during anesthesia. But to make it easier to drive the current, they generally are placed within a small envelope, and it is a sponge. It is a clean sponge that is it's just a normal sponge. It's a clean one. There are several tests with different types of materials. Some use gel. There's a sodium chloride, higher concentrations, more uncommonly, but normal practice, the more frequently applied protocols in clinical research, and the ones that are going towards clinical practice, they end up using biological serum because due to the ease of acquisition and due to its efficiency when it comes to conduction of current, why don't we just place adhesives like the ones we use in anesthesia? Well, as you can see in this photo and the upper center, the placement of the electrodes sometimes involves local positioning because, well, when there's hair and hair is a good, well, it kind of isolates electrical current. It's good at doing this. So if you place it very close to the scalp with biological serum, it makes conducing the current much easier and you can get through the hair more easily. It's interesting to mention that these devices, all of them, they can also have a control for resistance and amperance to diminish the risk of injuries and to try to guarantee that we are offering, we are delivering the right current range that is programmed by the doctor and by the researcher. When it comes to delivering this current, there can be an increase in temperature and it may not have the desired clinical effect. So these are the details that are key to define the success or not of the clinical research or the clinical therapy that we are aiming towards. Okay, but we see these images and simulation that continuous electrical current cannot reach the more exposed areas that are beneath the sky. We have a lot of gray matter beneath this. So how can the surface current reach, modulate pain processes? Well, the hypothesis that is generated to explain this clinical response depends a lot on the understanding of the components of the pain matrix, on the processing of the nociception and the pain experience. We know that there are several systems, and the central nervous system and the peripheric nervous system, especially developed for the perception of pain. We call it the nociceptive system. So going straight this the brain, the peripheric process. I want to point out a few cortical regions that are very much connected to this pain experience that are represented in this image. We have in the pain experience, we have the sensory and discriminative component that here we see it. It is in the bright purple pinkish. Let's see, it's pink. Discriminative component, which is the secondary sensitive, very close to the hematosensitive. This secondary somatosensory cortex has very close connections to the thalamus. And we know that it's a central point when it comes to processing pain. And on the affective component of pain, we have cortical regions that are very easily affectable through transcranial stimulation, magnetically as well as electrically, which is the prefrontal cortex, specifically the, pre, the prefrontal cortex. We can see later on that many of the protocols regarding pain, as well as neuropsychiatric patients, they focus their efforts on prefrontal cortex, especially the lateral, maybe the left lateral cortex, which has easy inference through measurements on the patient's cranium. The prefrontal cortex, you see, has connections with the insula the anterior cortex, the amygdala,
Campo.
and these connect to the hippocampus, the thalamus, and the brainstem. And if we remember our neural anatomy classes and brain processing classes on the prefrontal cortex and the anterior cortex, the amygdala, and the brainstem, we have relevant nucleus are responsible for an inhibitory system of when it comes to pain. So it's likely that if transcranial stimulation through a continuous current and the neural modulation techniques that are not invasive, they can help you when it comes to treating pain through the modulation on the sensory discriminative system and through the stimuli of the inhibitory system of pain. We access, we help to modulate this inhibitory system through the intimate contact that these neural networks have with the prefrontal cortex. Sorry about skipping slides over and over. This is a way to see the general landscape through which you try to explain the mechanisms thanks to which the non-invasive neural stimulation helps when it comes to pain processing. Sure, there's a lot more specific things. There are neural circuits that are more specific when it comes to the processing. But on the first approach, it gives you a very coherent idea. And in fact, we can learn about the electrical stimulation. There are studies showing positive results that are clinically positive on patients with very complex pathologies. So, okay, I understand that this is a current. We place some cathodes on the patient's head, and depending on where we want to stimulate the region, the cortical region of the neural matrix of pain that I want to try to apply to stimulate this inhibitory system or to help to control pain or different conditions. But what we have as scientific evidence goes. One of the biggest contributions of the Brazilian Journal of Anesthesia is spreading clinical research that is high quality. We know that there's a change of temperature. There's a lot of documentation when it comes to clinical experiences or clinical research. But what do we have that is more objective? Well, since there's a lot of pain syndromes, there's a lot of protocols of non-invasive brain stimulation. I use as a basis to share with you this review that was published in 2020 on the International Journal of Psychopharmacology. A few authors, I know them, and I like to say that on the world, they have a very strong push when it comes to research and development of brain non-invasive brain stimulation as magnetic transcranial magnetic stimulation. I know the main authors and the first author of this review was Felipe Freire, Professor Felipe Freire. He is Brazilian from Sao Paulo. He used to live in the US and he is a professor in the Harvard Medical School. He's one of the main researchers dedicated to transcranial stimulation. So Sandra Carvalho and Jorge Leite, they are researchers from Portugal. They also work in the area. Marcel Simis as well. Professor Volnegarno was a researcher from the Clinical University of Porto Alegre. Once again, he was my guidance orientator in Portugal. Professor André Brunoni, also from São Paulo, one of the biggest researchers when it comes to non-invasive neural model simulation, when it comes to treating depression, slow response, as well as refractory depression, as we used to call. And this is based partially on the neuromodulation research group. Sure, this is a review. This is described as the production of guidelines based on evidence and secondary meta-analysis. So this is a meta-analytical review with the intent of producing, of generating guidelines based on evidence for the use of transcranial direct instillation in neurological and psychiatric disorders. So this is going to be the side that is only dedicated to what will be their suggestion when it comes to transcranial neurostimulation in when it regards to pain. When we try to assess critically and scientific literature, it's important to know who is writing. So this is why I mentioned the researchers that I know, they are serious researchers. But once again, when we're going to assess scientific research, when know, okay, what are you talking about? This meta-analytical analysis. Researchers whose job is focusing on this line of research that we know we are human. There's probably going to be some kind of bias, as conscious as it would be to favor this technique. We need to be critical. So don't ask your hairdresser if you need a haircut, that kind of thing. As neutral as they'll try to be, their job is to cut hair. So they will favor you getting the haircut. As great as these people are, I know them personally. They're serious, they're dedicated to their job. They love the non-invasive area of research. We must remain a critical vision. So the researchers concluded that their proposal is for there to be a directive of non-invasive ablation when it comes to pain. And let us remember that this is a so we should note that there is a revision of literature from 2020 to be able to perform the sole production and surprise the journal had its peer review until 2020. What they found in regards to randomized studies that high quality comes to non-invasive continuous current stimulation within the cited conditions is that they are favorable. They would recommend the non-invasive continuous current stimulation anodol on M1 on the primary cortex for neuropathic pain. They would also recommend anodol on the TDCS M1 for fibromyalgia. They will also recommend the same setup, anodol setup on the primary cortex for migraines. It is not recommended against MPS, MPS syndrome, myofascial syndrome, because there is not enough evidence for it. They recommend the use of it, a favorable use, and probably it is probably effective anodal stimulation on the primary water cortex for post-operative acute pain. So, or an assistant, and it is not recommended for sternal stimulation for lower back pain for lumbago. Up to what I know, there is one clinical. So there is one research regarding lumbago and was not a positive effect. So as white coherent, there is no way for us to have a recommendation if we do not have evidence. They're not saying that there is evidence against the use of the stimulation for MPS and lumbago or for lumbago. They're saying that there's no recommendation because there is no information. There isn't, they cannot recommend anything. They can say yes or no because they can't have a position if there's not enough evidence. And for what is described here, they are speaking about a degree of recommendation. You need to remember and try to discern there is there's one thing, a degree of evidence, and then there's a degree of recommendation. These are randomized research. These are the advice that they assess as being high quality, that is relevant. They would recommend this within these indications that there was a site. When we look at the fold effect sizes, the size of the group effects, you can see that for some indications, these are pretty interesting numbers. Some are within a degree of 0, because this helps us in our understanding of the research as well. They also said that they could have some kind of relevant bias for recommendations. This is a publication from the same year, than the year 2021, on Lancet. For those working when it comes to pain, this
dor crônica, isso
During
é
the
uma
Lancet, there was a number of publications regarding chronic pain.
muito legal, muito
It was
interessante.
very
Então eles fizeram
interesting
bastante também
research where, amongst other things, there was also a
comparação
proposal for a new
de
classification of
fisiologia
pain
na dor
called
nociplática. Diferente, né, de
nociplastic pain,
uremia e outras condições
very
que também
interesting
a gente fala
condition
nessa
that fits
dissertação,
in,
destacando que
pointing
provavelmente
out
um
that
dos principais
likely one of the
mecanismos
main
nesse
mechanisms
sentido
and
não
reasons
existe uma
for this type of
evidência
pain, there is no
científica de dor
robust evidence
somática
of
ou de dor
somatic
neuropática
pain or
específica, talvez
neuropathic
a gente
specific
consideraria
pain
como a dor
that
nociplática.
might
Mas
be
como
dealing with
ele
nociplastic pain. But
efetivamente é estimulação
what is the relation
transcranial,
towards transcranial
eles,
stimulation?
segundo a
They,
Lance,
the Lancet
completamente
doctors, they are
independente
completely
dessa
independent from the
pesquisa
specific
de
research
posgrado na
in brain
pesquisa
neuromodulation that is non-invasive. They, in
trabalham muito
fact,
mais
these
com as
doctors, they work a lot more
invasiva
with invasive
e
stimulation
estimuladores medulares.
and
Eles também colocam na revisão
medular
deles, no posgrado
stimulators they
atual,
also place in
que
their
ele
revision, where they
serviu
try to define
para dor
what
crônica
worked for chronic pain,
em geral, citam a
general chronic
estimulação
pain,
transcraniana por corrente contínua
transcranial continuous
no
current
seu
stimulation,
olhar, no seu
in
julgamento
their
sobre a
eyes
capacidade de
regarding
dor,
their judgment
como
of the
provar
available literature as
para
favorable for
fibromialgia e
treating
dor neuropática.
fibromyalgia and neuropathic pain.
Voltando a como foi a
Going
revisão
back
da
to the
importação dos
revision
pesquisadores
composed
em
by
estimulação,
the
estimulação
neuromodulation
transcranial, eu
researchers,
tomei a liberdade
I
de fazer uma
took
tese
the liberty
complementar,
of bringing in
porque foi por eles mesmos para chegar às conclusões que eles trouxeram para a gente. E aqui, dos pontos,
one of
não
the points, not that I think that this removes validity from the conclusions or the
mas
suggestions
para
they had,
trabalhar a
but
gente como
for us
clínico,
to stay
médico,
attentive
investigador
as
científico,
clinicians, as
eles
interpreters
trouxeram
of
o
scientific
oscilador como
literature,
forma de
they
analisar
placed
a
a
informação quando a
score,
gente faz uma revisão
a
meta-analítica.
forest plot, where we have a
Para quem não está
meta-analysis. I
familiarizado,
don't know if you're very familiar with
ah,
this, but
existe efeito
when there is no
sobre a intervenção
effect
do tamanho do
or the
efeito
interpretation of the
da
size
intervenção
of the
estudada,
intervention is
vai cair
studied,
aqui no zero,
this will fall on
provavelmente, muito
zero.
provavelmente,
This is
quando se
likely
observa
when
efeito
you observe an
da
effect,
média do tamanho do efeito estudado vai
the
cair
mensch is
nessa
the effect of the study
esquerda,
will
ou
fall.
seja,
This number of to the left of zero will be favorable
quando o efeito é
when the
contrário
effect is counter
ao
to
efeito
the
estudado
effect that is
terapêutico,
studied
ou seja, ele vai ter a
therapeutically,
direita
the
do
side
efeito
effect
terapêutico,
will
como se fosse
go to the
como o
left of that
efeito
zero line. This is a
ativo.
very
Essa é a
rough
interpretação
way of
dos pesquisadores.
abbreviating
Terceiro
the
ponto,
forest plot, and you can observe
a
that
média
the
do
average
efeito na
of the
interpretação
size of
do
the
mesmo
effective
conforme
interpretation
a
of
André
these
Schmidt
authors
falou a
falls on the left
respeito da
side
estimulação
of the
transcraniana por
chart,
corrente contínua. Mas
favoring
reparem
transcranial stimulation from
menos
continuous
estudos
current, but affecting the
envolvidos,
weight of the
a
studies that were
maioria
involved.
deles possui tamanho do
Most of them
efeito
have a size, an
peculiar
effect
com
size
força
whose
através
trust
da placenta,
interval
que seria
goes
nociplástico,
through zero, which seem
porque
not
é
to have an
proporcional.
effect.
E tem
And
estudo
there is one
desenvolvido por
study
essa diretrizes
of the
internamente
lead
que
author of this
é
guideline
muito
that pulls
favorável
this average
e
very
muito efetivo.
favorably. So if we
Colocar uma intervenção
could focus on an
só
intervention
pelo pool effect size,
on the pool effect
essa
size of
interpretação seria
this
a mais positiva,
interpretation of this forest plot,
eu ficaria na dúvida, não fiquei
I
totalmente
would
convencido.
still be
Mas,
doubtful.
e muito
I
importante
wouldn't be so
ressaltar,
convinced,
não foi
but it's
uma
very important to
e
remember
não é
that
o
we
mesmo
are in a
medicamento que você
therapy.
administra, que é o mesmo medicamento aqui ou o mesmo medicamento na China ou
This
na Europa.
medication
Estamos
that
falando de uma
used here and in
intervenção
China and Europe.
no ser
This is an
humano,
intervention where a human being will be
onde
in touch with another,
os eletrodos na
will
cabeça
put
existem muitas
electrodes in their
variáveis
head, and there are several
que podem ser muito
variables where there
importantes
can
para uma
be an
decisão. Por
important
exemplo, a
evidence,
localização
for
dos eletrodos.
instance, the location of the
Aqui
electrodes,
nós
as we
estamos
said.
fazendo simulação de
Here,
bipolar
we're
onde
having several studies. They're putting together several studies that try to decipher this transcranial stimulation, which is useful or not for neuropathic pain. But here, we don't have any sort of discrimination regarding which was the situation where each of these studies were where they placed the electrodes. Sure, most of them were in the primary cortex, but a few of them weren't. And then there's another element involved. They're speaking about anodol and ME1 on the ME1 on the primary cortex, but a few times they say where the cathode was. Where was the cathodal stimulation? There are authors that put it in the shoulder to diminish the confusor effect, of the cathode on the cortex. There are authors that like to place it on this upper orbit, on the right upper orbit, that will have an inhibitory effect. There's also authors that place it against lateral. When it comes to studying migraines and speaking about regarding the clinician that is in charge of this, with research in charge of this, a meta-analysis pool effect size
que esa
does
intervención
not mean that this intervention will work on not on a patient, because this pool effect size is picking up every single patient from several pieces of research, put them in all in the same bag, and it gives you an average. They are mixing up patients with many different characteristics. They're mixing up experiments with very different parameters. When we try to translate this to my patient that is in front of me, I need to be very careful and understand if the characteristics of this specific patient are consistent with what was researched, the research that I chose as a base, what it is telling me about the therapy. It's not easy to interpret scientific literature, to give it to bedside and give it to your patient. But these are elements that we must keep in mind when it comes to trying to translate this into clinical practice. Today, I see this frequently in the Neuromodulation Institute. Due to this, I understand that there are colleagues that can be pretty skeptical when it comes to the effectiveness of non-invasive brain neural stimulation. As I said, I worked on the clinical side of things, a lot more on the magnetic side of things, because it's much more robust evidence. It was much better to find protocols, but it's still clinical research. I need to keep thinking that what profiles of patients do I want to provide for? Because these are very diverse patients. I can have very diverse patients, and maybe they could be high, they can be masking irrelevant clinical effect that is relating to my sample. Okay, with this scientific evidence available, the authors of this revision, they are favorable to recommending electrical transcranial stimulation, especially when it comes to anodal stimulation on the primary cortex for patients with neuropathic pain. And as described, neuropathic pain, generally, this is chronic, oral chronic pain. I like to focus on that side of things when I speak about the clinical side of things. I don't know how many of you have clinical experience with patients that have chronic pain, but a patient with neuropathic chronic pain, generally, these are patients that they are going through several medicines. They frequently have psychiatric comorbidities, so they're probably using some sort of inhibitor or sertraline, or they're using some sort of gabapentin, joint gabapentin, because these have neuralgias their neuromodulation also could act upon. So these are patients that consult and get to the clinic with chronic pain that they've been fighting for many years. So a patient that has already tried a lot of stuff and they still feel pain. If you show up to therapy without pharmacological interactions, without medicine that can add a little bit of an effect, maybe just a little bit of pain control for a patient that is suffering for a long time, that they cannot tolerate any other medication, this can be therapy that can change the person. In my experience in the institute, we already ran into patients that, oh, therapy, transcranial, that would diminish the intensity of pain in 40%. For somebody that's 40%, it might as well. But for somebody that is already using 3 or 4 medications and is dealing with adverse effects, a 40% in pain control, that's a different life. It's a new chance at life. So when we judge scientific literature, when it comes to neuromodulation, non-invasive neuromodulation, you always need to think about the patient's profile. You could think, the effect size isn't that big, but you remember this is against the placebo. So this therapy is superior to placebo effect when it comes to pain control. And for a patient, it can be clinically relevant. So we have evidence that it is subjective to a clinical effect. So what else could work? Fibromyalgia. For fibromyalgia, we could have the same, say, same type of clinical trials, bigger research like cardiologists, research of anticoagulants. We see clinical trials with hundreds of thousands of patients on normal, non-invasive neuromodulation. We have studies that regarding 20, 30 patients, a few of them with 100 patients. And we see clinical results that are pretty diverse. On one side, as researcher, I'm happy to see there's a bit of heterogeneity. This reflects real life as well. I'm glad to see that negative results are also communicated. I know how difficult it is to have a peer result, to accept a result with a negative result. But I understand as a clinician, we get annoyed, but we like things to work. But for fibromyalgia, we have to see the verse effects. We see a study that it pulls a lot of things, but in generally speaking, the pool effect size is favorable towards transcranial effect when it comes to fibromyalgia. And in fibromyalgia, well, we'll be able to get to diagnose this person has already gone through a lot of years for a person that they go for rheumatologists because it's part of research to be sure that there's no other specific cause of pain. So that finally they will get the conclusion that they have fibromyalgia. They have 8 years till they get to you. And that whole time, they've tried a lot of therapy, they've tried a lot of treatments, they've been taking a lot of medication, and they're going for therapy once again without reciprocal oncological. So they're presenting pain control for this patient. Maybe this 30% above pain would be a lot for this patient. For migraine, well, there's also a favorable outlook regarding transcranial stimulation when it comes to controlling migraines. And we have this conclusion regarding the assessment of two randomized trials when it comes to quality. For migraines, I believe my idea, but these are quality studies published in 2012. So what is the sample size? What is a good sample size to see that is an adequate therapy for clinical practice? What is a effect size that is acceptable for clinical practices? So what the research for migraine would have 1,000 patients when it comes to research? Well, that's probably there's probably no agreement, no categorical vision when it comes to interpretation of the authors. It could indicate this for migraines. So what migraine protocols? So just to poke at your curiosity, you can see that this study had the work of looking at research by research and representing which are the montages, experimental montages for transcranial therapy for migraines. You can see that there's a whole bunch of types of possibilities for experimental attempts. So we understand why it's so difficult to judge scientific evidence when it comes to transcranial stimulation for treating migraines, because every researcher is looking for a protocol that will work for them. So patient, you need to ask yourself this a lot. So what this actually work for? Is this the adequate stimulation? Which one of the montages is adequate for the patient? So just to add to this, what influences? Where do you place what influences? Where you place the electrodes, the size of the electrodes? What is the intensity of the current? How long the therapy will last? What is the type of pathology you're trying to treat? And which are the medications that the patient is already using that could get in the way of the effects of the transcranial electrical stimulation? So this research that anodal and cathodal simulation work for migraine, but there's no consensus on which is better, anodal or cathodal stimulation. So for anesthesiologists that are really closer to acute pain and transcranial transcranial stimulation, we have a crossflow that is more homogeneous. We have only these studies, but the conclusion on the pull effect size is favorable. On electrical stimulation, personally, I'm writing a protocol for research for knee pain and reviewing the literature amongst these three studies that were mentioned as positive, favorable. They showed that the diminished the consumption of opioids. But the strange thing is that what worked was not the anodal stimuli on the prefrontal cortex, was the anodal and the prefrontal. But that sort of runs away a bit from the rule of the studies that we've seen so far. And during my PhD, I managed to work with an anesthesiologist colleague who worked with transcranial research as well to diminish the consumption of opioids in post-operation. Dr. Hugo Ribeiro and his studies also showed that electrical transcranial stimulation diminished the use of opioids post-op. So this is something that I think is pretty interesting for us, very promissory. As anesthesiologists, we know how much medication we can add, but we know that also how many adverse effects are present. So you're going to have therapy with less adverse effects would be something that is much improvement for our clinical practice. So one final indication that was not cited by the researchers in the previous review, but also think it's very interesting due to the difficulty in controlling these patients and the stimulation, transcranial stimulation to direct continuous current or phantom pain. So these are Spanish researchers. So they found that 7 randomized control trials and gives an N of 210 patients. The conclusion is that anodic TDCS over the one contralateral or the M3, depending on the placement of the lesion of the phantom pain.
protocolos que eu comentei para vocês.
These protocols that I commented to you, they can diminish the intensity of pain in patients on with phantom pain limb, but they concluded what we concluded together. The studies that we had were studies with higher segmentation with therapy for clinical trials. So what are risks? What is the same intensity that is montage for transcranial stimulation? So on cathodes, for electrical stimulation, it doesn't work. Magnetic stimulation can work when employed correctly. Transcranial stimulation does not cause convulsions, but you need to be attentive because there are first degree burns. These are burns on the patient's heads when it comes to applying. There is also tingling or itching. There can be they can be dizzy frequently. They can cause your skin to turn red beneath the electrode on patients with THB, with bipolar patients can have issues with this, and it can cause tiredness. Who cannot use TDCS? These are brains that have duration in their cranium because you need to use the average radius of the cranium, the same principle we use on electroencephalography on as the patient. So if a patient has some sort of operation in there or a change of their anatomy, if their cranium is not shaped as usual, if you have uh, some sort of prosthetic intracranial implants, metallic, doesn't work. With skin cuts, you cannot place. And also remember to use clean sponges that are that are humid with physiological serum. So this is a very much studied therapy for pain treatment. It can be altered and to apply cortical researchers. So it's very much depending on the protocol of stimulation that is safe. And when it comes to pain, there is positive evidence for neuropathic pain, for migraine, phantom, limb phantom pain, and post-op pain. But to have this lasting effects, the person must perform the sessions, as we call them, induction, during these weeks at least, 2 weeks at least, and then if some patients simply do not respond, and we do not know why. I am open towards doubts. So at any point, so I work at the Hamburg Institute for Porto Alegre as well.
Perfeito, Jairo, excelente
Perfect.
apresentação, né? Espetacular. Parabéns, eu acho
Uh,
que
Great job.
realmente focar-se
Congratulations. I
nela é
think
uma
this
área
is
que
a
ainda
subject
não
that
tem
is
conhecimento de muitos
still not
colegas,
in the know-how of a
sejam
lot of
anestesiologistas,
colleagues,
até colegas que trabalham
anesthesiologists,
na área da
or
dor,
colleagues at
né?
work and the
E precisa ser
pain and
explorado
pain
de
management.
uma
This is a
forma um pouco
subject
mais
matter that must be
aprofundada,
approached
mesmo que ainda,
in
né,
evolution,
dentro
even
de uma
if,
área
as you
onde o
showed
nível
quite
de
clearly,
experiência ainda
the level
carece
of
de mais
evidence is
estudos,
still
né, para a gente
lacking
entender direito as
for us
principais
to understand
indicações da
the main
técnica, né? Mas
indications
desde que você trabalha nessa linha de pesquisa, né, eu pude acompanhar ao longo
when it
dos
comes
anos
to
você
research
se dedicando a isso, as evidências foram
dedicating to this.
surgindo,
The
né?
evidence
Você
would come up.
iniciou
And when you
aqui
started
com essa técnica
this
estudando
technique,
lá na
studying
pós-tese, né, ou mesmo antes da tese, nos trabalhos do professor Bonney,
diseases,
o nível de evidência era
Professor
mais
Bonet's
baixo
work,
ainda,
the
ainda
level of
havia
evidence was
muita,
even
eu acho que
lesser.
até o
It was
preconceito
quite
ainda
new. It was actually
maior
some
hoje,
prejudice that our
ainda
colleagues
de que
had.
a
It was
técnica,
even higher than
que
today.
é
So now we
realmente
understand it as a technique
realmente o valor que
that
merece,
does
quando
has the value
ainda
it
realmente
deserves as a
é
technique
uma alternativa
that
para esse
is
tratamento
an alternative
adequado
to
na área da
treatment that
dor,
is
né,
quite
como
important in
foi já
several
documentado
scenarios.
em diferentes cenários,
What is
e o
efficiency
especificamente
documented in several
interessando agora a questão
scenarios?
da
And
dor, que é
now
aquele grave
you
inicial,
really approach the
na
matter of
própria
pain, but that
natureza
initial
cerebral de
charge with a
diferentes
different approaches and different
desenvolvimentais
techniques that can be
indicações
used in
clínicas realmente
different
mostra o tamanho da
patients. It
importância de
shows you
carregar
the size
o
of where this
caminhão
can
da
get.
dor que a
There's
gente tem
still a
que
long track,
para
a long
gerar
path that we
evidências.
must take to
Eu
generate
vejo, né, os
evidence.
colegas que
So I will ask my
passam pelo
colleagues if
treinamento,
we have
temos aí
any
sim
questions.
questões e
We have the
respostas,
Q&A
e
resource
sim,
right
vocês
there at the
podem
bottom.
postar
You can
as suas
post
dúvidas. Eu
your
aproveito
doubts
para
and
iniciar,
questions. I'll
né,
start.
alguns questionamentos ao professor
I have a
Jairo,
few doubts for
aproveitando
Dr.
nossos
Professor
minutos aqui
Idle,
após a
making
aula,
use of our
inicialmente para
post-class time.
questionar algo a
First
respeito
off, to
das
ask
metodologias
regarding the
científicas dos
scientific
trabalhos,
methodology of the work,
especificamente para fazer o
specifically
seguramento desses
for the
trabalhos,
blinding.
da aplicação da
For
técnica. O senhor
blind
citou que há
blind trials,
uma
you
sensação de
mentioned that there
formigamento,
is a
falta de
feeling
fluido.
of
Como você consegue
tingling.
fazer
How do you
esses
control
estudos,
that? How
né?
do you make a blind
Existe alguma
study
possibilidade de uma
for
possível
this?
quebra
Is there a
dentro desses
possibility of
trabalhos?
breaking the blinding research when it has such a noticeable effect? And that's a critical point that we always research non-pharmacological research intervention. There's this human contact non-clinical research where neuromodulation, invasive neuromodulation. There are a few tools developed to try to guarantee this blinding magnetic stimulation in the same aspect, but by the same sound. Transcranial electrical stimulation, what what people tend to do is that there are devices through which you can pre-program the session for it to be a real session. They sort of base focus so this can be it so that the person that is in front of the patient will not know which therapy is being administered. That's a way to blind the therapist. There are devices that you can program the user, but the user, the patient, or the clinical research, or they may have a more economical test. Somebody from the lab will go program the device, and everything will be set up in an envelope. And this sort of therapist be blinded to the intervention, and for the patient that already was previously exposed, and then they can feel the itching, their skin could turn red. They turn to use a short period of ramp up and ramp down, and then they end up receiving the stimuli of seconds. And at the end of this 20 minutes of stimulation, those 30 minutes, once again, we have a ramp up and a ramp down. So if they were priorly exposed in expectation of having that redness, they will have the ramp up effect and the ramp down effect. If this has a clinical effect, the answer is no. As we said at the start, we know that we need at least 20 minutes to have a clinical effect and have this repeating to, in fact, say that it did happen. So it's very heuristic and a bit of a reality situation. Oh, but it was 5 seconds of ramp up. They were induced alterations, yes, during seconds, but it's not generating a long-term appreciation. It's not going to generate long-term depression. So on the research groups that we've seen, we tend to include question, a questionnaire on the one hand, adverse effect. We know that placebos can generate adverse sensations. Patients that can have placebos, sometimes they can have adverse effects. And we ask for the patient what they think of the protocol, that they got the real therapy or sham therapy, and generally with these blinding measures, this generally like it works out for the patient. They'll guess they'll have their real therapy, but as a revision, these are elements that you need to pay attention to. When we are researchers, we're always excited to get the results. We change the mechanism, and there's a control copy and paste protocols. For those that are judging the scientific validity of the work, these details are very important for us to, in fact, the therapy is a placebo effect. We know that a placebo is relevant, but these chronic conditions, these psychiatric comorbidities, they have a placebo effect. They have a consistent effect that must be judged. If you're going to make the patient go through the job of having a different therapy that is superior to a placebo.
Perfeito. Até
Perfect.
aproveitando essa questão,
So making
do que
use of
você
the
seria a minha próxima
placebo
pergunta,
effect, that will be in the next
você,
my next
nos
question.
trabalhos que você acompanhou e que
In
mesmo
the
realizou
work that
depois,
you've
você viu que
accompanied,
a
you
média de
observed that
efeito
the
placebo
average of the
no
placebo
grupo
effect
controle é
in the
maior do que
control
outras
group
intervenções
is
em
higher
pain,
than
por
other
exemplo,
interventions when it comes to
intervenções
the pain, or
equivalentes
would it be
uma
equivalent,
sequela da dor, seja
like a
uma dor
placebo
crônica ou um
effect when it comes to
problema
chronic
recorrente.
pain?
Nos
It's a
trabalhos que
relevant
você
effect
fez,
for
tem uma
work due to
possibilidade
having
de
a
alta
percentage that's
eficiência, né,
relatively
dos
high when it comes to
trabalhos,
placebo
trabalhos
effect on
diversos
the work
de
and
atendimento
adverse
a intervenções na área
therapies
da
and
dor.
interventions when it comes to pain.
muito parecido com o que a gente
Very
observa
similar to
com outras terapias, realmente.
what we see with our therapies as well.
Tem fator
There is a factor
relevante
that is
que é
relevant
muito difícil
that is very
de
difficult
pegar
to
em revisor para quem é
notice as
leitor,
a revisor.
que
Those of
eu
you that
vi
are
isso,
viewers that
eu
are readers,
vejo isso hoje no
I
instituto
see that
também,
in the institute as well,
e é que essa interação
and is that
humana é
this
terapêutica.
human interaction is therapeutic as well,
Independente da
independently
intervenção,
of
seja, na verdade,
the
relativa
kind of
que você
real
está
or
fazendo,
sham interaction that you're
o
having.
ambiente é terapêutico
The
também.
environment
E
is
você vai ter um
therapeutic as well.
componente de
I say this
clínico,
as a
né, quando você
clinical
está com o
component.
paciente,
We're
a
speaking
atenção
about
que
a
o paciente está
patient, the
ganhando, o
attention that a patient
comportamental que
is
você
getting, the
está
care
demonstrando, o interesse que está
that you're
demonstrando no
showing, the
paciente,
interest that you're showing
gera
toward to
efeito
their
terapêutico
well-being.
também. Então, na
This
pesquisa
is therapeutic
clínica,
as well. So in
quando a gente
clinical
desenha essas
research,
experimentais, a gente
when we
tem
have
que
this
tentar ter o cuidado
create this
para ambos os
experimental
braços
actions, we need
terem
to be
as
careful to
mesmas
keep
condições
to provide the
clínicas
same
para a
clinical
gente
conditions
depois,
so
como
that we can later,
post-pesquisador, poder falar,
as a
olha, a
researcher, we
terapia
can
de
say,
fato
okay,
funcionou.
our
Olha,
therapy
esse
was in
contexto
fact
clínico tudo de fora
superior
foi
to this
oferecendo para o
clinical
paciente. E a
context that we are
gente vê
providing
isso,
for the patient. We see
infelizmente, na
this.
medicina tem muito charlatão. E
You
o
see this a
charlatão,
lot, and we see a lot of
geralmente,
charlatans in
quem
medicine,
convence,
and
porque desenvolve
you know we
atenção,
because it involves attention that
do paciente que fazem
sort
sentido.
of
Uma
they tell
pessoa com
people
mais
what they want to hear, and a
força,
person
às
that
vezes pode ser um
on the
pouco
back
mais
is a bit more robust,
difícil
maybe
de
they'll have a
convencer,
very
porque ele
bad
fala:
condition
"Mas tem
because
uma evidência que
they're
funciona". Mas
skeptics.
por que não
Eh,
funciona? É a realidade. E o
It
paciente
could
não
work,
quer
but it
escutar
could
isso.
not.
Lá no
And
começo da
patients hate to
terapia,
hear
ele
that.
fala:
They
"Vamos
want
fazer
somebody to tell
sessão
them that it's going to
final".
work,
Tudo
that
bem,
they'll be
vamos, o
fine.
terapeuta
And
acha
sure,
importante.
as a
Agora,
therapist, that's
quem tem essa
important, but
experiência mais grossa lá na parte acadêmica,
people
é
like to
difícil
hear
você
that. It's difficult when you,
seduzir o paciente com essas falácias.
it's difficult to convince a patient like that.
É perfeito, Jairo. Isso é super
Anyway,
importante, ainda
that's
mais
very
na área do
important, even
desenvolvimento
more when it
que
comes
a
to
gente
pain.
observa na prática,
We
né?
observe
E
in
como a
practice
questão do pesquisador, da frieza ali do
how
pesquisador,
how
isso é
researchers they can be
realmente
cold,
alguém que é muito embasado em
but that
argumentos,
is
né?
very
Então
much
eles não querem ouvir.
based on
Mas é a
evidence. That's not
realidade, né?
what
E
people want to
isso
hear, what a
na
patient wants to
pesquisa
hear, but it's
científica
reality
tem que ser
regarding
sempre
scientific
considerado e às
research.
vezes a
It
verdade
must
ela vai
also be,
mudando por
and
conta da
sometimes
prática,
pain go, truth
em
goes through
científicas,
several
né? Eventualmente várias
phases, and
apresentações,
eventually
mas sim, tem
several
essa característica
interventions.
aí
We
que é
have
legal.
this
Entrando
characteristic in
só na
literature.
questão da parte
Going
clínica, né,
into
da
the
parte de
clinical
intervenção,
side,
você
when it
comentou
comes to
a respeito
intervention,
das
we
sessões de
commented regarding
repetição.
the
Vocês
sessions of
fazem mais
repetition.
quantas sessões? Você mantém por um período longo de tempo? Como isso
You keep this
funciona?
for a longer
Aproveitando
period of
essa
time,
questão
how
do
this works,
tempo,
and
né?
when it comes to
Como foi o
time,
paciente
what
recidiva?
is
Você
the
teve uma melhora? O
recession rate?
paciente eventualmente
Did you patients
fibromialgia,
that
numa
have a
hérnia,
fibromyalgia or a
né?
number of
Você
cycles
acaba depois de uma recidiva
you end up sort
evoluindo,
of
essa
having a
recidiva
fallback?
evolui
How
e
long
você
does
passa
this
novamente a
does this
aplicação desse
occur?
tratamento.
How
Eu
long does
fiz
it
o
take for this to
follow-up desses
happen?
pacientes. É
What is the
basicamente
follow-up for this
que se resume
patient?
essa pergunta.
That
O
is the question.
meu viés, o meu disclosure em relação a essa
And
pergunta é que no
idea is
instituto
that in
ele
the
faz um
institute,
perfil clínico,
the
que
institute
seria
was
tendo esse
clinical,
follow-up
there's this
mais prolongado,
follow-up,
mais longo, mais duradouro,
longest,
e mais
and
duradouro é
the
ótimo,
lasting one
porque
is
realmente de instituto, estou falando de longo prazo, né, de
instance
instituto
that
de
it
longo
lasted, it
longo
took 2 years. The
ah,
institute,
meu viés é que
my
no clinical
bias is
clínico a
that
gente trabalha
this
muito mais
clinical
com a
environment work a lot
magnética
more
transcraniana.
with magnetic
A gente faz a
transcranial.
estimulação elétrica transcraniana
So
e a
transcranial
gente depois
electrical
faz a estimulação
stimulation and
magnética
rock this
transcraniana.
transcranial stimulation.
Não tenho
And
certeza que a
I'm
gente
not
pode fazer
sure
essa
if we
extrapolação
can have this
da
extrapolation and
estimulação
thinking that
magnética
we have the magnetic
para a
stimulation.
estimulação elétrica.
This is useful
Ah,
electrical stimulation,
o
and
que a gente tem observado na estimulação magnética, que é aquilo que eu posso
the
dar para
stimulation is that
você
which,
desde esse ponto de vista clínico,
from the
é
point,
que
from the
existe
clinical
um
point of
fator
view, is
pelo
that there are
qual
a
com
few
frequência o
factors
paciente
which frequently the patient
recai
has
de alguma
sort of
maneira, né?
falls back. We can see an
Geralmente,
improvement.
geralmente 5 sessões
Generally,
iniciais, o
5 initial
paciente larga
sessions,
dessa
the
disciplina.
patient ends up
Até
saying
existe
no.
uma corte
There
bem
is a
legal
pretty interesting
da Europa que faz um
test in
follow-up
Europe
longo
that
com
has a
pacientes com
follow up
dor
with
crônica
patients with
neuropática
chronic
e dor crônica
neuropathic
neuropática é
pain.
bastante dificilíssimo,
Patient,
talvez
it's very
com
difficult for
tratamento
patients that
tratamento farmacológico,
pharmacological treatments
pós-operatório, cirurgias que não deram
post-op
certo,
patients,
pacientes com dor
patients with
falácica, refratários, eles fazem estimulação
refractive pain. In
magnética,
fact,
trabalham aquilo que você
the
dá
transcranial
e chega num
stimulation is
ponto onde
observed
geralmente
that
começa a responder a
they
resposta da
generally
quarta,
start
quinta
response
sessão.
starting for
Aí
fourth
você
or fifth session. Starting
já
there,
foi usado pela quarta
you can have a
sessão.
response. You can see the patient is having a
Até
response effect.
25% dos
Up to
pacientes têm resposta,
25% of the patients have a
definitivamente
response.
Hoje não sabemos por quê. Com estimulação
Or
elétrica
in the
funciona
light,
25%
the
mais do que outros.
stimulation,
E a gente tem que ser honesto
they
com o
can work,
paciente.
but
Aquele EP científico, cara, quando eu expliquei, nós já com todo mundo tentamos,
we
e ele
explained that
falou,
as we
mas
attempted and it's worth it. So it's
funcionou
35%
muito
of
bem,
ones that
muito
respond.
bem.
A
Uma
few of them
um
work
percentual
very well, but
assustador.
50%
E
improve
os outros
pain,
50,
and other
55%
50,
foi considerado
55%
30,
are the ones
50%
that
da dor.
have 30,
Uma
50%
vez
of
que você
pain.
atinge esse
Once
controle da
you've
dor,
reached this
é
control of pain,
razoável começar a
it is
passar para a terapia. Não
reasonable
precisa fazer
to
todos os
pass on
dias.
to therapy. You don't need to do this
Quanto
every day.
tempo dura o paciente
And
com
how
dor
long does
crônica,
it last for a
uma vez
controlled
atinge
pain?
esse controle da
Once they've
dor
reached the pain
crônica
control
neuropática?
from neuropathic
Em
pain,
média,
on
de
average,
10 a 15 dias. Ou seja, o
10 to
paciente tem
15
que ter
days.
esse
But
controle
this
da
is
dor. Ele
like
deve
this
fazer a
pain
terapia
control.
uma vez por semana,
You
uma
have to do
vez
the
cada
therapy
15
once per
dias.
week, once every
Há
15 days.
muitas indicações para paciente.
But it's very variable from patient to patient. So that's when we get the experience of the clinical feeling of the contact of the clinician with the patient's proximity.
Em pacientes com fibromialgia,
Patients with fibromyalgia,
a estimulação magnética
magnetic
transcraniana
stimulation, transcranial
funciona
stimulation,
melhor
it
para
works
controle da
better
fadiga,
for
do
controlling
piloramento, da
fatigue,
lentidão do pensamento.
that
A maneira
slowness of
protocolo
thought,
pode funcionar
depending on
bem
the
para
protocol.
controle da
It could
depressão,
work well for
para reduzir a
controlling
depressão, melhorar
depression
as outras
to
intervenções para
improve
fibromialgia.
other interventions for
Unicamente para
fibromyalgia.
dor,
The only really for
ela tem
pain,
menos
it's
respostas
not the
na
best
avaliação clínica.
response in
Eu
my
digo isso porque
clinical
os
research because I
processos
say this
da
because the
fibromialgia
processes
trazem
for
uma
fibromyalgia
linguagem
is a language
insatisfação com a vida.
or
Dizer
insatisfaction. It's a
péssimo dor foi
language of
péssimo,
insatisfaction, like
bonito foi
to live with
bom.
pain.
Naqueles que têm uma
But
boa
on
resposta
those that
para
have a
dor,
good
na
response to
verdade a gente
pain,
tem uma clínica neuropática.
referring to
A
neuropathic
gente vê um
pain, that
progresso quando o
we can see at
paciente
least 10
está
sessions to say,
programado
okay, there's an
para fazer
improvement with
uma
pain,
neuropática
chronic
especificamente, que vai
neuropathic
fazer
pain,
4 ou 5 sessões,
4 to 5
ele
sessions.
melhora 10 a 15%.
Mine lasts twice as
Então,
much.
ele consegue
But
atingir
once you've
esse
managed to reach,
plateau
experience
feito no
this
analgésico,
plateau
a
of
gente
analgesic
trabalha
effect,
mais.
this
Por
can last a
isso,
bit longer.
a 20 dias,
Every
a
15
1 mês,
days, once a month,
tranquilamente. E para
practically.
fibromialgia,
But
como
fibromyalgia,
vocês sabem, tem aqueles
as you
fatores,
know,
né? Acontece uma situação emocional
Verdade.
difícil,
happens.
uma situação social complicada,
It's
o
a
emocional vem como uma
complex
avalanche, dá um
situation. There's
desespero.
an avalanche.
Mas, quando o paciente já tinha
But
atingido um
since the
patamar
patient could
controlador
have had a
de
certain
sensação,
level of
já
pain
pode
control, they
trabalhar
can
com uma
turn
dor potencial
around a bit
maiores.
more
No caso
quickly.
aqui da
But once
clínica
again, we're
2,
talking
acontece
about
muito
a
nesse
clinical
estudo,
experience of
e esse é
2
um
years,
falante clínico
and
mesmo,
this is a
ponto afirmado por
clinical
eles. E
hunch
tem um estudo que tem effects follow-up que
study, a
firma com o
follow-up
supervisor
study
para os números são esses. Essa última
that
parte
shows
é
the numbers, and
realmente
that's the final
puramente
part of it.
clínico. A gente tem um
As
Exato,
resultado
once
mas
again, this is a clinical
não,
hunch.
mas eu acho que é isso, até por ser uma técnica tão nova, a gente ainda não tem
With it being such a new
informações na literatura de
technique,
maneira tão claras ainda, né? Então é bem
the
importante você
literature is not
compartilhar
so
sua experiência
clear.
nisso. E até aproveitando essa
And
questão,
actually,
meu último
using this
questionamento, uma questão
this
bem prática
question
mesmo para o dia a dia do
as a
clínico, né?
practical
Para o
usage
clínico que está vendo a tua aula e que
as
eventualmente
in this
trabalha com
class.
dor e
And they work
quer
with pain
aplicar
and
a técnica,
to use
essas técnicas, esses
these
conjuntos de
techniques
técnicas para aquisição dos equipamentos.
for
É
acquiring
muito
equipment
caro, há
is
muito
very
custo para o
expensive. It's
investimento do
very, there's
profissional
a
para
high cost
intervir no
for the
consultório, para ter esse tipo de
professional to
tecnologia no
intervene
consultório.
on
Isso é uma questão.
on the medical office.
E a
This is
outra
one
questão
question. And
é
second
existe já
question is there
reconhecimento
is
das
already a
técnicas
recognition
da
of the
ANS ou
techniques
qual
on
tem que
the
ser então
NS, on
os
the NS
convênios que
all, and
cobrem essa
the
técnica ou ainda é
medical
algo
plans they
que
cover
não
this
caminhou
technique, or
nesse
is this
sentido e
something
qual
that
é a
has not
perspectiva
changed? What is
de
the
cobertura
perspective
por parte dos convênios e
of
deles na
coverage
intervenção?
on the side of the medical coverage
eu
plans and
considero que já
intervention?
está documentado mesmo a estimulação elétrica, a estimulação
So the
magnética transcraniana. A
transcranial
estimulação
stimulation,
elétrica
so the
transcraniana
electrical
não
stimulation,
tem uma
they
codificação
do
no
not
Brasil,
have a
no tratamento
codification
SUS,
on
especificamente.
the
Ahn,
public health
tem
system.
muita atenção por outros profissionais da
There's a
saúde,
lot of
médicos,
tension
fisioterapeutas,
on the physical
fonoaudiólogos.
therapist, phonologist,
Tanto é que a Associação
because
Brasileira da Fisioterapia tem um curso
physical
específico
therapy
para
is
a
a
formação de
specific
fisioterapeutas da
cost
estimulação elétrica e
for this
vibração craniana.
stimulation,
Tem
transcranial
os termos e
stimulation, and
regulamentações
they
específicos
have
de tratamento de estresse,
specific
quem,
regulation
onde, quais são as
to
características
tell
do
you
curso,
who,
para
which are
fazer
the
o curso
characteristics
poder
the
fazer a
therapist, so that the
técnica.
therapist can do so.
No Conselho Federal de
I didn't, on
Medicina
the Federal
existe
Council of Medicine, there
regulamentação
are
para
regulations
a aplicação da
for the
estimulação elétrica
application of
transcraniana,
medical stimulation,
uma
transcranial
resolução de
stimulation,
2012
resolution of the year 2012,
que basicamente
but
restringe a estimulação
basically
magnética
this
transcraniana, conforme essa resolução, para depressão,
resolution is that this is for
esgotamento,
depression
né?
and for slow
Especificamente para
response
fazer o tratamento ou planejamento de
treatment and the
neurocirurgia,
planning of
para
neurosurgery
áreas
to look for areas
eloquentes
that are
junto com
eloquent
neuronavegação.
with neural navigation.
Mas a estimulação
But
magnética transcraniana,
magnetic
ela
transcranial
tem
neural
sim
stimulation,
um
they
código
have
específico no
a
tabela SUS,
specific code
já
through
fez
the
parte
the
da
SUS,
da
public health
ANS.
system, part of the NS
Portanto, em
code,
algum
and
momento os
at
convênios
some point the
estiverem
health plans, they were forced to pay on transcranial stimulation, but you're no longer part of the ENs. And from that point of view, all the medical exercise of through the health plans, the magnetic stimulation is easier. There is a code that regulates this, and there's the code of the Brazilian Medical Association for magnetic cranial stimulation. There's also implementation to administer transcranial stimulation and for transcranial stimulation, because when it comes to rehabilitation, there's a larger volume than what we have for chronic pain with favorable positive results. This is something that aphasia, motor regulation, neural degenerative diseases, there is a body of evidence that is more robust. When it comes to the cost, as you asked me, the transcranial stimulation is actually funny. There are several American sites. Many have the device at home. I have not advised you to this because that's a current that you place on your head. But it's important to know that it exists and the vision of a researcher in the area. So don't do this at home. Things can go really badly if you're gonna put electricity on your head. But because it's a more these are simpler devices. It's not so expensive on scientific fairs, the events where I ran into a few representatives and distributors, but we on the side of be responsible on my end about the cranial stimulation, but it's not something that is absurd. It's not something that for a clinician that wants to have this on their office to be able to offer this to their patients. Magnetics therapy, there is more control. It's much more strict control, technically speaking. It's much more rigorous, and there is a much more elevated cost, much more elevated cost of electrical. So for the dental office, for the Federal Council of Medicine, as there is evidence that can induce this, you need to have all the support material available. There needs to be a stock, or you need to have a monitor. You need to have material for endoscopy, equipment for endoscopy that have oxygen. So the equipment can be more expensive, and the adequation of the office for a therapy would be more expensive as well.
Perfeito, Jairo, perfeito.
Okay, great,
Realmente
Jairo.
foi
I
extremamente
think
claro
that that was
essa
very
tua
clear, very
observação
complete
no
presentation.
começo, né,
On
nos
top
teus
of that,
questionamentos, a gente pôde abordar
on
desde a
your
questão
questions, you can
da
approach
pesquisa
this starting
científica na
from
área, da
scientific
questão dos
research,
práticos, então
sector
fenomenal.
of practical matters. So
Agradeço
great.
muito
I'm very
aí
thankful
a atenção, né, a tua
for your attention
disponibilidade
and your
para
availability.
fazer esse webinar
So it was
conosco
good to do this webinar
e
with us,
agradeço
and I'm
bastante também
thankful
a
for everybody being
metodologia
here,
que
your
foi
attention.
proposta,
I will
né?
see
Teremos
you
um webinar
in the
no
next
mês que vem, na última
webinar next
quinta-feira do
month,
mês,
last
o
Thursday of the
próximo
month,
webinar do Brazilian Journal.
next webinar, the
Muito
Brazilian
obrigado,
Journal.
viu? E boa noite a
Thank you
todos.
very much, and thank
Muito
you.
obrigado.
Good evening, everyone.